Good evening and welcome to one and all. Myself, Rupsha from CLIRNET, the designated session assistant. For a seamless experience of the session, CLIRNET is very proud to be a digital partner of this event organized by Association of Pediatric Surgical Oncology. And the topic of today's session is Tumor Board Meeting. CLIRNET is India's most trusted and widely used digitech platform with multiple enriching services exclusively for doctors. So let's begin today's session with a short video. Okay, so now I would like to invite Dr. Basant Kumar, sir. Over to you, sir. Kindly proceed with your talk.
Yeah, thank you. Thank you, Richa. Good evening, everyone. Thanks for joining us. On behalf of Team APSO, that is the Association of Pediatric Surgical Oncology, a subsection of IAPS, I welcome you all in our third tumor board meeting. Today, we are going to discuss two patients having sacrococcygeal mass. They are very interesting cases. And my resident, Dr. Pujna Kanaganti, is going to present these cases. She is MCS third year student at SGPJMS Lucknow in Department of Pediatric Surgery.
यूरिन आउटपुट कितना आ रहा है बेबी ऑफ लवप्रीत का? यूरिन आउटपुट.
Dr. Shreya, can you please mute yourself? Thank you.
During presentation and discussion, you can write your queries and chat in your comment in the chat box, and Dr. Manoj Joshi or Dr. Santosh Mahalik will take care of that one by one after presentation. So without wasting the time, I invite our chairperson, Dr. Sushmita Bhatnagar ma'am, to say a few words and also introduce our panelist today. Ma'am, it's
Yes,
yours.
I'm here. Thank you so much, Dr. Basant. Welcome, 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 welcome all our esteemed faculty and our esteemed members, because unless there is an amalgamation of the presenter, the faculty and the members with active participation, this program or these sessions are not going to be very fruitful. So I urge all of y'all to actually ask your questions, discuss, because even sacrococcygeal teratoma, which seems to be such a easy to manage and such a easily diagnosable condition, can present the way it has presented, which you will learn during the presentations today. So let me introduce to you. I'll just share my screen. Right. So our esteemed pediatric oncosurgeon, pediatric surgeon faculty is Dr. Pablo. Can you see my screen?
Ma'am, your screen
Not
is
yet.
not sharing.
Not sharing.
Ma'am, are you doing it clicking on the... Yes, ma'am, it is sharing now.
Yes, yes.
Oh.
Just make it full screen, that's it.
Yes, of course. So Dr. Pablo Lobos, he is affiliated to Hospital Italiano di Buenos Aires in Argentina. He is also the secretary, the honorary secretary of International Pediatric Surgical Oncology section of PSO-IAPS. He is the chairman and a full professor of pediatric surgery. He is also director of the postgraduate training program in pediatric surgery, as well as the director of the fellowship on pediatric surgical oncology and director of fellowship on pediatric intestinal failure. Wow. He is also the Vice Chair of Intestinal Rehabilitation and Transplantation Program and a member of the Vascular Anomalies Clinic. He has multiple affiliations to various organizations and also have published innumerable papers. So I also welcome Dr. Sonali Mohapatra. She is a pediatric hemato-oncologist. She is from PGIMER Chandigarh, and currently she is affiliated as an additional professor to the Department of Pediatric Medical Oncology Hematology at AIMS Bhubaneswar. Welcome, Dr. Pablo and Dr. Sonali. Over to you, Dr. Basant.
Oh, thank you, ma'am. Actually, there are three colleagues, my colleague from SGPGI in this panel, and it is unfortunate I could not make the slide, but I can introduce. First is Dr. Punita Lal, ma'am. She is a senior professor in the Department of Radiation Oncology, and she has a special interest in childhood malignancy. Ma'am, a long CV, but unfortunately I could not get that. Welcome, ma'am. Second is my colleague Dr. Rajanikant Yadav. He is additional professor in the Department of Radio Diagnosis. He is big help in the department for me to manage all such kind of patient. His special area of interest is hepatopancreaticobiliary surgery, GI, and peripheral vascular interventions. Basically, he is an intervention radiologist. Welcome, friend. And third one is my colleague, Dr. Neha Nigam. She is associate professor in the Department of Pathology, and she has a special interest in hepatobiliary pathology and transplant pathology. Welcome, Neha, to today's tumor board. Now I call my resident Pujna. Can you share your screen and start your presentation?
Yes, sir.
Yes. Go ahead.
Greetings, everyone. I'm Dr. Pujna, final year MCS resident in the Department of Pediatric Surgery, SGPGL, Lucknow. Today, we are going to start the tumor board meeting, and our discussion today is sacrococcygeal mass. We are going to share two interesting cases of the sacrococcygeal mass that we had dealt in the last year. So our first case is a 8-month-old female child presented to our department with the complaints of slow growing mass in the sacral region observed by the parents themselves since the birth. Economically, they are socially very poor, and also their approach to the hospital services and also other medical services is also very poor. So, according to the description by the mother, it was initially the size of the marble observed by herself, and it was progressed to the present size, as can be seen on the clinical picture here. And she also had said that it had ruptured in the first week of the life itself, and there was a serious discharge for 2 to 3 days observed by the mother. And she had shown this symptom to the local practitioner who was a quack and who had assured her that it was okay for this child and that child can be managed conservatively only. And child doesn't have any other constitutional symptoms, and also entire perinatal history of the child is uneventful. So, but still, the parent had the concern, so she had presented here. And when we had examined the patient, she was very active, and also per abdomen, and also we had examined the local area, that is sacral region. The per abdomen, there is no mass or any inguinal lymphadenopathy, but there is a mass of size 4 into 3 centimeters, which was firm in nature, and also immobile, just present over the natal cleft. And we can also appreciate a sinus opening seen over the mass with no active discharge. Rectally, there was the firm mass palpable on the posterior wall of the rectum with mobile mucosa over the mass. And there is no narrowing of the anal canal. So we had proceeded with the investigations of the patient, starting with the routine blood investigations, which were within the normal limits, and her tumor markers, especially serum alpha fetoprotein, is slightly raised. According to the AFP mammogram, for her age, it should be less than 10. But for her, as we can see here, it is almost 94.1 nanograms per milliliters. And rest of the tumor markers like HCG and LDH, HCG is normal limits, but whereas LDH is slightly raised, that is 800 units per liter. Chest X-ray is normal. So we had proceeded with the other radiological investigations in the form of ultrasound and also CT angio and MRI. Ultrasound had shown that there is a heterogeneously hypoechoic lesion of the size 2.5 into 2.3 centimeters in the presacral region at the level of the tip of the coccyx, with the area of calcification and also cystic areas. CT angio, unfortunately, we are not able to retrieve them. But MRI pelvis was done, which had showed the solid cystic region, as can be appreciated here, behind the rectum, but in front of the sacrum. And also it is extending into the subcutaneous plane, as can be seen here, with the lesion reaching up to the skin surface. And there is no obvious extension into the spinal canal, as can be appreciated here in the fourth picture and also in the third picture. And also here we can appreciate that is entirely presacral mass with slight extension into the extrapelvic region. So after the counseling of the parents and also in the view of our presentation, we had taken the patient for the upfront surgery uh, that is sacrococcygeal excision, mass excision along with the coccyzactomy. Here in the intraoperative picture, we can appreciate the plane of the dissection that we had done, and also here we can appreciate the coccyzactomy post tissue dissection here. So, and after the surgery, entire post-surgery period was uneventful, and we had repeated serum alpha-fetoproteins after day 3, which was the 36.5 nanograms per milliliters. Histopathology examination was reported as the mature sacrococcygeal teratoma with no immature elements. It had shown 3 components, that is ectodermal. Here we can appreciate the squamous and the keratin-filled cystic space. Here we can appreciate the mature glial tissue. And here we can appreciate the sebaceous glands also, and endodermal components like glandular spaces lined by columnar epithelium, and also mesodermal components like cartilage and also the blood vessels. So, as it was suggestive of the mature teratoma only, she was advised for the regular follow-ups, that is at 3-monthly interval. So, at the 3-month follow-up, her serum alpha-fetoprotein was 8.5 nanograms per milliliters, and the rest of the clinical examination was also within the normal limits. But at the 6 months follow-up, all the clinical examination was within the normal limits. Like per abdomen, there is no mass or any recurrence, and per rectally also no mass palpable. But there is a but there is a raised AFP of 13,000 nanograms per milliliters. So suspecting the recurrence, we had proceeded with the metastatic workup in view of their restrained finances also. We had straight away proceeded with the FDG PET-CT, as it can give the entire information whether it is metastatic or the local recurrence or recurrence anywhere. It had shown that there is a metabolically active soft tissue in the mid pelvis region of the size 3.6 into 3.4 into 3.3 centimeters, and there is no other metabolically active lesion. Unfortunately, we are not able to retrieve the PET-CT. I'm sorry for that. So for the recurrence, patient was started on the PEB regimen, that is bleomycin, etoposide, and the cisplatin. Presently, she is at the follow-up with the completion of 2 cycles of the chemo with a good response to chemo. That is in the terms of decreasing trends of the alpha-fetoprotein levels. So post second cycle completion, her serum alpha-fetoproteins are 624 nanograms per ml. Moving on to the second case, a 14-month-old female child with the uneventful perinatal history presented with the complaints of slow-growing mass observed by the parents in the sacrococcygeal region for the 3 months. Here we can appreciate the mass in the sacrococcygeal region. So they had taken the patient to a local practitioner who had diagnosed the mass as a abscess, and he had done incision and drainage. And then again, there is a recurrence in the size of the mass. So he had proceeded with the repetition of the incision and drainage, and he had taken a tissue biopsy at that time. And also there was a non-healing ulcer that was developed after the second time incision and the drainage. So patient had presented here with the complaint of serosanguinous discharge also from the ulcer for the 15 days. And also there is a history of high-grade intermittent fever for 10 days. And there are other symptoms like straining to pass the stool, but no difficulty in the micturition. So on examination, there is a single hard mass of the size of the 6 into 5 centimeters over the sacral region was present, as I had shown in the previous picture. And also here we can appreciate the mass along with the ulcer regions, which was of the size 3 into 1 centimeters with inflamed margins and with the base covered with the slough, and active serous sanguinous ooze was there. There was a bilateral inguinal lymphadenopathy of variable size also. Rectally, there is a hard nodulatory palpable over the posterior wall with rounded upper border, but with immobile mucosa. And also there is a narrowing of the anal canal. So general examination also, child was very irritable and dehydrated with the HB of 5.6 gram%. And also her tumor markers like serum alpha-fetoprotein was highly elevated, that is 96,000 nanograms per milliliters. But other tumor markers like HCG was within the normal limits. Again, LDH was elevated. So we had optimized the patient in the terms of blood and blood products transfusion and also other supportive treatment, including the antibiotics. We had done the chest X-ray, which had showed the features suggestive of the lung metastasis, as can be appreciated on the X-ray here. And ultrasound showed that a heterogeneous mass, solid mass noted in the sacral region with no internal calcifications or necrotic regions. Further imaging had revealed that there is a solid cystic mass, as can be seen here, of the size 12.5 into 7 into 7.4 centimeters, that was anteriorly displacing the rectum, and also it was abutting the bilateral iliac arteries. And on the chest X-ray, there was multiple nodules seen bilaterally involving the lung parenchyma and also the pleura. And also there is a erosion of the S5 vertebra and also collapse of the D11. We had proceeded with the metastatic workup also, which had showed the heterodense mass of the size 7.4 into 5.8 into 4.8 centimeters, arising from the sacrum and the coccyx. And also there was a heavy uptake in the pleura and the parenchyma of the bilateral lungs. And also there is uptake in the right inguinal lymph nodes also. And also partial collapse of the D11 vertebra was appreciated. So the outside tissue biopsy that was taken by the local practitioner, we had retrieved that and was sent for the histopathology in the institute. It was suggestive of the small round cell tumor, as can be appreciated here, with the hyalinized tissue also. And it was positive for the AFP and also CD99. So these are the features suggestive of the yolk sac tumor. So after the counseling of the parents about the malignant nature and also the metastasis, we had started the patient on the PEB regimen and we had given the child 4 cycles. Patient had tolerated chemotherapy well with no complications like neutropenia or immunosuppression. And there is a clinical improvement in the mass size also. And also there is a healing of ulcer. And we had observed decreasing trend in the serum AFP levels also, which I will show later. So we had, after the completion of the 4 cycles, we had proceeded with the repeat imaging mainly for the preoperative evaluation, which had showed a decrease in the size of the mass, as can be appreciated here, but with the persistence of D11 collapse. And as can be seen here, lung nodules had improved in their size and also in their number. We had repeated the metastatic workup also, which had showed that the mass had decreased in the size compared to the previous PET CT in the terms of the mainly in the size and also EBID uptake. And also there is absence of uptake in the lung nodules and also in the inguinal lymph nodes. Again, collapse of the D11 vertebra was noted. So as the patient had completed 4 cycles and also had shown the good chemo response, we had taken the patient for the surgery, that is excision of the mass along the coccyxectomy. Here we are unable to retrieve the entire intra pictures, but this is the post-operative picture after the small dissection or the incomplete dissection of the tumor. After this, we had proceeded with the further dissection of the tumor and the coccyxectomy also. And post-operative period was uneventful. And the immediate post-operative period that we had repeated after day 3, serum alpha-fetoprotein was 6.5 nanograms per milliliters. Histopathology has shown that the tumor we had sent is free of the residual tumor. And here we can appreciate that there is only histiocytes with no tumor cells and it was also AFP negative. Right now, patient is under follow-up after the completion of all the 6 cycles of the chemo and right now she is under 1 month follow-up. Here we can appreciate the decreasing trend of the AFP since from the presentation, that is 96,000 nanograms per milliliters, and at 1 month follow-up after the chemo completion, the AFP levels of 1.5 nanograms per milliliters.
Thank you, Pujna. Before going to any comment or discussion, I would like to ask my panelist, if you have any query in cases, please go ahead for that. Sushmita,
I have a question about the compromise of the D11 vertebra in the second case. Did the FDG PET scan show any compromise, which we can
no, sir. There was no, sir. There was uptake. FDG uptake was not there. It was collapsed, but uptake was not there. Even in lung nodule and D5 vertebra also, there was no any FDG uptake.
Okay, but that collapse was assumed as a bone metastasis
Yes.
but metastatic compromise of the tumor. Okay.
Yeah, sir. Agreed. It is metastasis, but probably chemotherapy take care of that.
I had one query about
Yeah,
meaning about both the patients. In the first patient, you had mentioned that CT angio was done.
Yes.
What was the indication for CT angio?
CT angio for resectability. Look for resectability, ma'am. We can remove it.
So is that a routine which is done generally?
Yes, ma'am. Definitely. CT chest and local area is routine at our center.
No, angio. I'm talking of CT angio.
Yes, ma'am. This is routine. We always do CT angio, triple phase CT angio.
Okay. So there in first patient as well as in second patient, I was actually wondering, in the first patient, alpha fetoprotein was raised right in the beginning itself, right?
Yeah, this is my query, ma'am. Actually, first case, if we look carefully, it presented as a sacrococcygeal teratoma. Most probably, it is a benign lesion. And only apart from two issues are there. Only child is presented late, that is 8 months of age, and other is alpha fetoprotein is raised. But it denotes that there is immature component is there or some malignant component is there. But histopathology showed, and it was reviewed when child presented after 6 months. Dr. Neha herself reviewed cut the multiple section and saw there was complete mature cells. There was no any immaturity or any malignant cell is there. And in spite of that, after 6 months, he presented with raised alpha fetoprotein. So is it possible if we excise a teratoma or a benign lesion in sacrococcygeal area, and if we leave some kind of tissue, little bit tissue there, that is, it is a suboptimal excision. So is it possible that tissue can change to malignant behavior? Sorry.
So let Dr. Neha comment on this, because if there is no we always have seen a correlation between the raised alpha fetoprotein levels to the histopathology. It is very unusual, or I would say really very rare to see that there is alpha fetoprotein which is raised, but the tumor is mature and there is no malignant component. So Neha, Dr. Neha.
Yes, ma'am.
Yeah.
Okay, ma'am, what my opinion is that at the time of the biopsy, at the time of the initial slides, when we have the initial slides, the AFP levels were around 20. I think if
94.
it is 94 at that time. Okay, so at that time also it is increased. But we have the mass is around 5 centimeter in size, and we have taken 9 to 10 sections from the random areas, from the solid areas, which are more frequently composed of the immature component. But we don't have any immature component. We could have immature component in mesenchymal, in ectodermal component, endodermal, but all endo, meso components are benign, totally benign. I reviewed the slides thoroughly, and if needed, I might take some more sections as well. But these are the okay. If required, I might take more sections.
So there is one more aspect that we need to take into consideration, is that this child has had right. So after 6 months of the surgery, this child had a raised alpha fetoprotein of how much? Around 1 lakh or something, no? How much was it?
10,000, more than 10,000, man.
More than 10,000.
9,000.
So, which also again indicates that there was
हम
some.
बनवा रहे हैं, घर हम बनवा रहे हैं. तुम क्या बात
you
करती
have
हो
been
कुल्लू?
missed out on histopathology. Whatever you have seen
खाली
is
ये चीज
premature.
बोलती हो. हम
But
घर
the
बनवा
thing
रहे हैं
that
माँ बाप
he
के
had,
लिए.
Dr. Sandeep, can you please
हाँ,
mute?
बात क्या लगता है?
Please. Okay.
There is definitely something that we need to look at, and that
Yes,
is
ma'am, go ahead.
we are all learning from each other. So that is what we are discussing. If the alpha fetoprotein is raised and histopathology is mature, what should be done? CLIRNET
Raksha, please take care of it. Oh.
Can't
Yes,
somebody
sir.
mute this person, whoever it may
We don't
be?
have that control. Otherwise, we would have done it. The CLIRNET team has to do it. I don't know what.
I have muted them. I have muted, ma'am.
Okay, please take care, henceforth. So, Dr. Pablo, your hand is raised. I'm sure you have some comments.
Yes, I just wanted to make a comment. I agree that the 94 value for the AFP is significant to consider given the recurrence that we have later. A question for the surgeons who were there. Do you think that probably 94 is very small amount of elevated AFP, so probably we should consider that there may be a very small foci of yolk cell tumor within the tumor, but if the pathologist didn't found it in the resected piece, for the surgeons, do you think that perhaps there may be a small residual
Yes.
within the pelvis, considering that the recurrence is a lesion, lateral to the rectum, and when we see the preoperative images, there was a component of the tumor laterally to the rectum inside the pelvis that perhaps when we approach the tumor only from the from the sacrococcygeal incision, sometimes you may leave some small piece of tumor behind within the pelvis. That's why in some cases we usually use a laparoscopic approach first to to explore the inside the pelvis and eventually free the amount of tumor that you can find within the pelvis, and then go for the second approach to the sacrococcygeal position and resect the remaining tumor.
Yeah, sir. I fully agree with, and I am explaining myself too by this explanation because I have operated only by sacral approach, and most probably I left some part of that tumor inside the pelvis, and later it converts to in malignant. But this is a big learning for me. Ki even in benign tumor in sacrococcygeal teratoma, I have to remove every bit of tissue. That is the learning of this case. Agreed, sir. Fully agreed. Any comment?
So, when do you do post surgery AFP levels after the patient is operated?
Just after surgery, within 1 or 2 days before discharge, and after 3 months, 3 monthly for 1 year, and then 3 monthly for 2 years, and then 6 monthly for 1 year, and then yearly.
Basant, what about the half-life of AFP?
That is 7 days, sir.
Then why are you doing it after 2 days?
So basically, if you do it post 7 days, you'll get to know whether they
yes, sir. It is 7 days, and before discharge, we are also doing that. But I have seen when we excise the mass, every time alpha fetoprotein level get drops
immediately.
Yeah, sir. I have seen. This is also day 3. It is 64 to become 32.
So
I got your question, sir.
Dr. Basant, that sometimes happens post-operatively, but ideally it is after 7 days so that you have subsequent increasing or not increasing. So there's a slight read that is okay. So basically to have a fall, then it helps after 7 days or 5 to 7 days. Basically.
Yes, agreed.
But we generally don't do CT angio and all for sacrococcygeal teratomas. So if at all there's a doubt, one does an MRI. I don't know how CT angio helps.
Yeah, even I was wondering. That is why I had asked Dr. Basant, is that your protocol? Because I don't know. Is that a protocol?
Actually,
ask the radiologist.
Are you looking for the blood supply from the aorta or something? Why do you want to do a CT angio? You think some big vessel is coming from the...
Probably he was saying CT to get better visualization of vessels.
No, what is the vessel which is worrying there? Only that median sacral coming from the aorta. That anyway you sacral approach, you tie it. Unless until, as the foreigner was saying, you do an abdominal approach first in these type 4 sacrococcygeal teratomas. There I think there may be an indication.
I had one question.
See,
So
sometimes elevated AFP comes even there's no local recurrence. You have late pulmonary metastasis. So I don't know when there's elevated AFP after the removal, whether you have to do a PET scan and see what's happening somewhere else.
Hello, sir. This is our routine protocol to go for CT. We are not comfortable with MRI because of in my institute there is only one MRI machine and there is logistic also. Child need little bit sedation and all these things. So we are more comfortable with CT scan, and it is routine to look every aspect of that tumor locally. So it's our protocol to go for CT NGO. And your other question is that for PET scan, actually we look because we have locally we excised and I was quite confident that I have removed all the tumor along with the abnormal skin overlying sacrococcygeal area. So I thought it might be a remote recurrence. So that's why I went for.
I agree. That's what you have to do. That's what
Yeah.
one has to do a PET scan. Because sometimes
Yes,
there will be recurrence somewhere else. It happens in all these tumors.
Lung.
That's
Yeah.
correct. But
So,
sacrococcygeal lesion is never benign. I don't know how you thought of a benign lesion. I have never seen in 40 years a benign sacrococcygeal lesion. It's always been malignant only. You have to take it as malignant. So I don't know. I don't get this point of yours. I have not seen a benign sacrococcygeal lesion in an infant or a child. What lesion are you trying to tell is benign in sacrococcygeal?
So sacrococcygeal teratoma is benign in most of the early neonatal and early few months.
No, it's a tumor, benign. No, I mean, what?
It's a mature teratoma. So mature teratoma is considered as benign. Obviously, the chances of malignant transformation and some amount of immature elements can be there. But what you're saying, Bagdi sir, that it is benign is only we are talking about the mature teratomas.
Bagdi sir, there is a COG protocol is there that defines it is if it is a extragonadal tumor and having this immature component at sacrococcygeal, surgery is the only indication. There is no indication for chemotherapy.
Yeah. Only a recurrence is there, then malignancy is there.
Then, yes.
In our large series in ICH, we had like 1 or 2, where malignant, we had to give chemo, metastasis in the lung, especially the pre-sacral varieties, they present late because they're not out at all.
Agreed, sir.
So, Dr.
Sir, please.
I wanted to know, I think what we should do is we should all raise our virtual hands whenever we want to talk. Otherwise, there is an overlap. Many people are talking at the same time.
Oh, sorry.
Can I go ahead? Can I continue to talk? So, Dr. Basant, I was just wondering, do you have the pictures of the CT or MR when the alpha fetoprotein was raised 10,000 or something after 6 months? Do you have those pictures? Because talking of recurrence, then we need to actually evaluate the local area more than the metastatic, meaning.
We are planning to go for that, ma'am, actually. There is financial issue. So definitely within 1 or 2 days, child with us, we will go for that.
Acha, so we don't know actually whether there is a local recurrence or not.
Yeah, there is local recurrence. We already did the FDG PET scan. Then no. Pujna, are you there?
Yes, sir, I'm here.
So that slide.
Yes, sir. Come.
Go on first case.
Yes, sir. This is the first case.
Okay.
There is a metabolic active soft tissue in the mid pelvis region.
This one. We did FDG PET scan, ma'am, but the CT was still not done because of there was I arranged some kind of things and then FDG was done because we are suspecting it might be a local, it might be a systemic recurrence. So that's why I have to choose either do CT or FDG PET. So I choose an FDG PET. definitely I will go for local. And it shows, you can see their active soft tissue mass in mid pelvic region, that is 3.6 to 3.4 by 3.3 centimeter.
So it is mentioned here, it is PET CT. If it is PET CT, then you would have the anatomical picture also, and the functional, the PET as well as CT was done.
Yeah, ma'am. My next question to expert, if there is a local recurrence and it is such a small lesion, 3.6 to 3.4, 3.3. So is it chemotherapy is sufficient for it, or I should go for excision of that residual mass? Because chemotherapy is quite effective, and I have found there is, I think, St. Jude, they have studies on it. If a residual tumor less approximately 3 to 4 centimeter, and it is chemosensitive, and after chemo, if it is not active, so we can leave it. We have already given only 2 cycles of chemotherapy, and alpha fetoprotein is falling. We also plan to give at least 2 more, and after that we will repeat it. If it is active, so definitely we need to go and excise it. If it metabolically not active, so can we leave it?
Okay, so we have Dr. Sonali here. Dr. Sonali, can you come in, because we were waiting for you to join. So welcome, Dr. Sonali. Dr. Sonali is our pediatric oncologist, medical oncologist. So please come in, Dr. Sonali.
Good evening, everyone. Regarding the first case, I think even if the alpha fetoprotein was marginally raised, but if the surgeon feels that they can excise it, and he has rightly excised it, and that was right, even if it is, we'll consider that alpha fetoprotein 94 at 8 months of age, if we put it in the nomogram, it is raised for the age. But if a surgeon feels that he can excise it, well, he can go and excise it. So that the approach is right. And after that, normally we do alpha fetoprotein monitoring, like when the patient is being discharged, like already discussed that alpha fetoprotein half-life is around 7 days. So when the patient is normally after surgery is being discharged on day 8 or day 10 of life, during that time we can repeat the alpha fetoprotein, and then every 3 monthly. Imaging for relapse we can do if the alpha fetoprotein is raised. So here, I don't know, alpha fetoprotein was initially was falling down. It was somewhere around 36. And then the treating team found that the alpha fetoprotein is raised 36,000 something. So in between, maybe at 3 months of post-surgery, if it would have been done, then they have found that it is on increasing trend. So now, they have rightly given chemotherapy, as I found, I understood that it is local relapse.
Okay.
Local relapse.
How many cycles we need? Sorry, ma'am.
No, it's fine. So we can go ahead, and you have given 2 cycles of chemotherapy. And normally less than 11 years of age, we go for JAB chemotherapy, that is carboplatin based, as for our convenience. And it is also recommended that less than 11 years we can go for JAB, and more than 11 years we can go for BEP, that is cisplatin based chemotherapy. We prefer personally because of the load, and JAB chemotherapy can be given on daycare basis. For cisplatin, we have to admit and give lots of fluid, and that will be, our bed will be occupied for minimum of 4-5-6 days. So that's why you personally feel that JAB chemotherapy. And also it was found that there is no difference if the young is less than 11 years. There is no difference in the survival if you give JAB chemotherapy, that is over 3 days, and that is carboplatin based, rather than a BEP, that is cisplatin based. And here actually we can give chemotherapy, and I think for sacrococcygeal teratoma, whenever feasible, they can go for surgery when the size has come down and surgeon is feeling that they can remove it. But of course, it has to be non-mutilating surgery. And after that, again, we'll give chemotherapy. But here, as it is relapse and AFP count is more than 10,000, so better I will go for 6 cycles of chemotherapy in total.
Okay.
Pre and post in total.
Okay, madam. Thank you, ma'am. And what
Can I come in, please? If you don't mind, can I come in?
Yes, sir.
Yes, sir.
Please.
Hello.
Yes, sir. Please go ahead, sir.
So we're talking about local relapse, and we're talking about giving chemotherapy and then coming back and removing the residual tumor. My experience has been, if you're caught up in this situation, then by the time you're given 2 or 3 cycles for that residual or recurrent tumor, there is no imaging evaluable tumor really left.
Yes.
So if that is not there, where will you go to excises? So I follow a little differently. I would give chemotherapy once the AFP levels come normal, 2 cycles after that. But then, of course, you have to also take in mind how much chemotherapy cumulatively you have been giving pre and post-op or whatever. So there are many times when you will not be able to see it on MRI and CT and whatnot after you've given some more chemotherapy for that, say, a less than centimeter or whatever little residual, whatever you may have left. So I would rather give 2 cycles more after the AFPs have come normal. So this is how I go about it.
Completely agree with you, sir. So it will be AFP based, like the monitoring will be AFP based, and surgery should be non-mutilating. And if the surgeon feels that, and on imaging, if there is something left behind, and surgeon feels that they can take it out without any mutilating surgery, then we should go for surgery.
And one more point I wish to make is that we surgeons should kind of make sure that we know all the techniques possible available in the market. We should not leave any residual tumor behind. If you think, I'm sorry to say, I've seen somebody in my own department removing piecemeal, the sacrococcygeal teratoma, which was in an older child and which was obviously malignant. I mean, that's not the way to do it. So if you think that you may leave some pre-sacral tumor or abdominal component behind, just tackle the abdominal component separately from another incision. You know how to do laparoscopy, fine, but I am not a very laparoscopy fan. Do a good job at first grade so that you don't end up in trouble like residuals and this and that later.
Sir, as long as alpha beta protein is decreasing, it is responding, I'll leave it to you, sir.
Yeah, thank you.
Ajay sir, any role of radiotherapy in such cases during recurrence?
Radiotherapy, I've reviewed this whole literature about in germ cell tumors, the role of radiotherapy. It has been given in very disappointing kind of situations where nothing is coming. But no paper really says that radiotherapy really works in germ cell tumors. It will not work. It's been given when somebody is, totally desperate and nothing is happening. There are some articles in the past which have mentioned that, but radiotherapy really no.
Yeah.
Absolutely.
Punita ma'am, can you comment? Punita ma'am?
Yes, we would love to hear from Dr. Punita. She is the radiotherapist and her experience in sacrococcygeal teratoma. She's here around, isn't she?
Okay, Dr. Rajni is here. Rajni, can you tell, is it possible to see any component of germ cell tumor radiologically in sacrococcygeal teratoma by CT?
By CT, we cannot tell if there is any component of germ cell tumor. The only thing that we can tell by imaging, these tumors are cystic and solid. Usually cystic and solid. And what we know is that if there's a larger cystic component, that suggests that there is more element of the mature component, and that tumor is more likely to be benign. So I don't know whether the more solid component, it's more likely to be malignant, and that's how the imaging tells us.
Okay, thank you, Rajni. Now coming to second case, I want to our panelists and my seniors that that child responded well by chemotherapy although she has stage 4 disease, lung nodule is there, bony mets are there, there was a big local mass. And after chemotherapy, 4 cycle of chemotherapy, I have excised the mass. And then repeated the FDG. That was all nodule in the lung. They are persisting, but they are inactive nodules, even over the bone, and it is more than 1 centimeter. Even there was a inguinal lymph node. I have also excised that during surgery, in spite of it was not active metabolically. So my question is that if it is more than 1 centimeter and there is a single nodule or 2 nodule in the lung, we should go excise it or just follow it.
Our policy in my institution is that we go there and we go for surgery and resect all the images that we have still at the CT scan after chemotherapy. I have personally done some big resections of big nodules scar, and when you go, it's a bit disappointing that when you go to the pathologic analysis, you can't find any viable tumor there. But our oncologists are still asking us to resect them just to be sure you are not leaving viable tissue, tumoral tissue there.
Yeah. Okay.
So how
Any
many
other comment
are there, Dr. Basant? Earlier, I think I remember that more than 50 nodules were there, 50. Am I right? In the chest?
Yeah, ma'am. There was multiple, ma'am. I can't count that. Huh?
And what is the CT showing after chemotherapy?
After
How many
chemotherapy,
nodules are still there?
4 or 5.
No uptake in lung nodules. This is the one, right? This is
No, ma'am. There was. This is no uptake in lung nodule. I think this is not the complete. They have mentioned the size of that lung nodule too. That was not mentioned here. Puzna, can you remember that?
Sir, sorry to dig in between. This was 50 nodules were mentioned. Largest of the size 1.8 into 1.5 2 centimeters that was mentioned.
Okay. More than 1 centimeter.
Yes, sir.
Okay.
So you have the pictures of the CT scan of this pre and post? Because we are not able to kind of, without the pictures, it is very difficult to even imagine okay, what was the situation earlier and what is it now.
Ma'am, if you see the chest itself, if you see the chest X-ray itself in the pre-operative period, you'll find there are very large nodules in the upper zones, which Dr. Pujna did not show very well. If you show the chest X-ray, look at the upper lobes, it is filled with these kind of large nodules, as you can see in this section. See the upper lobes in the X-rays, there are a lot of round opacities like cannonballs, we call them cannonball metastasis. Lots of them are there, particularly on the right side. And the clearer ones are seen on the left side. So I think the chest must have been filled with these nodules. Particularly the ones on the left, two of them very clearly, very large nodules.
Right. So this was before chemotherapy and post chemotherapy. Can you show the pictures, please?
Ma'am, as can be appreciated here, there is a decrease in the number and also in the size.
Okay.
Rajni, can you comment on these CT films?
Yes, sir. So she's showing at least two clearly defined nodules on both near the hilum. You can see in the lower CT images. The lowest CT images, the two of them, you can see there are 2 nodules near the hilum. So I think the rest of the nodules have like kind of disappeared. And PET scan will usually pick up when there is the size of the nodule is more than 1 centimeter. So something that has come down in size, usually PET scan will not pick up those nodules.
Oh, you.
So what should be done to these nodules? They should actually be excised. Dr. Pablo, this is what you were mentioning, that the lung nodules need to be excised. Am I right?
Yes, I would do that.
So this is both sides. So bilateral thoracotomy will be required.
Sternotomy.
Yes, in a small child like this, perhaps we should do anterior bilateral thoracotomy, like a clamshell approach without sectioning the sternum. It's usually very useful approach for that.
So if the alpha-fetoprotein has come back to normal, still we should be going ahead and resecting the lung nodules.
Well, that's a good question, but I think that probably our oncologists would suggest to go for surgery, even if the AFP is normal.
Right. Okay. Can we take the questions from the audience, please? Dr. Manoj, can you ask all the questions that have been asked in the chat box?
Yeah, good evening. There are couple of questions and comments in chat box. Am I audible? Yeah.
Yes, very much. Little louder will be better.
Dr. Salim Nazki is asking that do you perform a full body scan preoperatively in all the patients?
No.
So
no was. When required, when we suspect metastasis, then we will go for PET scan.
Okay. Dr. Ankur Mandelia is posting that having histopathology examination of mature teratoma and post-operatively AFP raised, did this case merit adjuvant chemotherapy?
Yeah, ma'am, please.
Sorry, I couldn't hear.
Medical oncologist may answer.
Medical.
Can you please repeat the question?
The AFP was not normalizing. The histopathological examination was mature teratoma, and the post of AFP is raised. So, do you need to give adjuvant chemotherapy?
It is upfront surgery. I assume that upfront surgery is done.
Ma'am, I can simplify the question. My question is that if preoperatively alpha-fetoprotein is more than 90 and after surgery it is 36, that is still high for that age. So is adjuvant chemotherapy is advisable or not?
Wait, actually.
Okay.
I think we should wait for some time and see the pattern, whether alpha-fetoprotein is further decreasing or increasing. Then accordingly, we can take a call. Based on a single value, there should not be knee-jerk reaction.
Yeah, in this case, ma'am, initially it was 36, then it came out to normal after three months. And then again after 6 months, it goes up more than 10,000.
Dr.
Sarin, something? Yeah, the question is that did your histopathologist tell you how many cuts or how much did you view? You know, it's very possible that the few cuts are taken and a small element of yolk sac tumor is missed, which has already given some micrometastasis. So, of course, now it's very, very important for I'm sure there must be some pathologists also today as consultant, usually you people call it, that they should do enough and more cuts, you know. And secondly, that 36 which you're talking about, now when you told me you do AFP after 2 days also, when was that done? Was that done after 2 days or was it done after that half-life of AFP was gone?
That was day 7, sir. It was not day 2.
Day 7 also maybe a little, I mean, I would rather wait for another 3-4 more days before I do it. But surely if something like 10,000 has come at 6 months, you know it, that you got malignancy somewhere. I believe that is the time when you should do some imaging. I am not that rich guy as you SGPGI guys are, that I will do a PET scan. I rather go for the areas where I should be able to see where it would have metastasized, in the local or maybe the lungs or whatever. But sure, at times you need to do PET scan. But I don't know. Now more and more people start PET scan for every solid tumor. And India is a poor country. Chandrayaan भेज दिया, that doesn't mean that you still have patients dying of diarrhea, malnutrition. That you do PET scan for every patient. Yeah, please.
So just to clarify, we don't do PET scan for staging. So local imaging is a must, and HRCT chest is a must. Bone scan we try to do, but due to the overload, sometimes we are able to get the date post chemotherapy because we cannot wait. But we try to do CT chest and bone scan. PET CT we don't do in every case. And like the first question you were talking about, like if alpha fetoprotein has not come down, then again we have to see that whether we have done the staging workup properly. So we'll see the alpha fetoprotein level, how it is going. And if you think that you have done the surgery and after surgery, the histopathology is mature teratoma, but alpha fetoprotein level is consistently increasing, then again we have to re-evaluate where were we missing.
Okay.
Dr. Sonali, this alpha fetoprotein had come back to normal at 3 months. It was only at 6 months that it rose again. So the protocol what Dr. Basant follows is every 3 months alpha fetoprotein post-op. So in the second or third alpha fetoprotein level was raised, but it had normalized. So we had discussed before you joined about the mismatch between the initial alpha fetoprotein raised levels with the histopathology report. And when there is a mismatch, then what should be done? So ideally, whenever there is a mismatch, this is my opinion, we need to absolutely be very certain on histopathology, and we need to do multiple cuts. Even if we need to do 100 cuts, 100 slides or 100 different sections, we should do it and not just let it go that, okay, raised alpha fetoprotein is okay. Because recurrence means it's a very, very big downfall, basically. So I think that is my opinion. But I am sure our pathologist here also needs to say something, and Dr. Pablo also, in case if he has seen any such situation where there has been a mismatch between the clinical presentation, the alpha fetoprotein level, and the histopathology.
Yes, ma'am.
Neha, please.
Yes, sure, ma'am. We do consider the mildly raised or raised AFP levels at the time of the reporting. So normally in the 5 centimeter mass, we might have the 3/4 section plus 1 centimeter section per 1 section per centimeter. So maximum 5 sections from this specimen. But we took around 9 sections in this specimen. And what my idea is, now this is from the surgeon side. They have to raise the query whether the levels were normalized or not after the surgery. Because at the time of reporting, it is very difficult to take as many sections as possible because the levels are, there is only one value. And we do take the ample amount of sections from that.
Yes, Neha, I agree. Actually, taking 200 or 100 section is very difficult,
possible,
especially
sir.
such a busy hospital. And if you don't know the...
and there is some protocol. There is some protocol. Even it is written in the grossing book as well. You have to take, if the size is 3 centimeter, you have to take 2 sections. And with 1 centimeter increase in size, you have to take 1 section per centimeter. So around 4 or 5 sections with this specimen is suffice. But if the levels were not normalized, if query comes from the surgeon side, we can recross. There is no issue.
There is raised hand. Please go ahead. I can't see the name of person who is raising his hand.
There is no other hand raised. Dr. Sareen has already commented, and I think
forgotten to drop down.
Okay.
Comment
there is a comment in this regard from Dr. Debashish Sahu that AFP, which is not normalizing after 2 half-lives, is considered stage 2 according to Cox staging, and that requires chemo.
Okay.
I would agree with that, but the question is, if you have a such a small amount of AFP elevated before surgery, and there are two values, because you had 94 just before the surgery, and you had 36 after the surgery. And although it was normalized at 3 months, I think that was an issue just immediately after the surgery. I would also suggest to my pathologist to go for more cuts and thinner cuts, because we are looking for a very small amount of yolk cell tumor. And one possibility is that you may have missed just a small foci of tumor within the anatomical piece. And the other possibility is that the surgeon left a residual within the pelvis, which had inside a small yolk cell tumor. So that's the two possibilities. So perhaps even if you have a mismatch between the pathology and the AFP levels, I would have been perhaps more a closer follow-up of the patient within the few weeks after surgery, and even perhaps made an MRI after 1 month or something to look if there was some tumoral residual within the pelvis.
Yeah, you're absolutely right. I want to emphasize again that we as surgeons should have zero tolerance to recurrence. We should not have a recurrence at all, and any recurrence for any child. See, it may be a huge institute, lot of patients, but unless we have that in mind, we will not be able to progress. We will not be able to learn. We will not be able to get better, and we will not be able to get more better outcomes in terms of any tumor. Why should we talk of only sacrococcygeal teratoma? It is a general statement that I'm making actually. So if we have that in mind, then see, we are all learning over here. Now we have not been seeing a mismatch between, these things earlier. If there is alpha fetoprotein raised, then we do fine. But there is, and here we have had a recurrence. This child has had a recurrence. So if we all learn from this, then whenever there is a raised alpha fetoprotein level, then we must be able to review the slides, do any further studies if required, and also have more sections, meaning 100 was what I mentioned was, as many as possible. That was my intention of saying. It may not be possible in 5 centimeters, 100 sections, but what I wanted to say is that as many as possible, and be 100% clear and be very, very sure that we are not missing out on anything. That's all I wanted to emphasize on. So thank you. And any more questions from?
There are a couple of more questions if we take. Dr. Kranti Swagatika is asking about correlation between alpha fetoprotein level and metastasis. And also, is there any condition where sacrococcygeal teratoma becomes inoperable?
Yes, it becomes inoperable. I can show you so many slides. Patients come late knowing the tumor was there for 3 years. It's all fixed to the pelvis and, going out as a growth, infected growth from the buttocks. All kind of things are still seen in India.
Still with rectum, yeah.
Yeah, so all those things. So basically, identify them as early as possible. And I for one, feel that our ASHA workers, you see, not everybody stays in Delhi and Mumbai and Lucknow. They live deep into those interiors. So ASHA workers should be taught to pick up these solid tumors very early. And all they need to do is to tell them to take them to a good tertiary center. Unless that happens, we'll still keep on getting sacrococcygeal teratomas or Wilms tumor, which were first noticed 2 years back. And they come with absolutely dismal prognosis. I mean, you just can't do much about them. And one more line, I must emphasize what Sushmita was saying. Recurrences, even in if it happens in our hands in Delhi institutes, the people don't want to, they may agree to initially get the patient, once recurrence occurs, no, they usually will not accept to have another course of treatment and this and that. And in that case, to have them, not jumping, they will do some half-hearted thing, and they will avoid at all costs. We are in teaching institutes and we keep on giving our surgeries to residents and whatnot, even in my own thing. But by favoring your students doing such surgeries and having recurrences means hell for the patients. That should never happen.
So there are more questions. Do we have time? Should I take it? Or?
Yes, I think, yes, we should take the questions and then end the session.
So Dr. Monica Bhagat is asking, is PET-CT really useful in sacrococcygeal teratoma over conventional imaging? And any additional information we get in PET-CT? Similar question is by Akshay B. Kalawant. How sensitive is PET-CT in cases of germ cell tumor?
So because nobody is saying anything, from my knowledge, I can say that PET is not the standard investigation for all pediatric solid tumors. It is restricted for some few solid tumors where it works very well. And when we combine PET with CT scan, the amount of radiation that the child gets is enormous. I think that as a primary modality, we must go for MRI because that gives much better soft tissue delineation. And also we can perform a whole body MRI, which will give a complete workup of even metastasis. And this has been done, this is being done in many centers. Now, if you are giving one anesthesia or sedation, depending on the age of the child, then you can evaluate the entire body. Even the staging can be done with a whole body MRI. So we have to start thinking of the future, of the child as well, because the amount of radiation, and it's not just one CT or one PET scan that is being done. If it is being done repeatedly, then imagine the amount of radiation that the child gets. We need to be sensitized to the amount of radiation we are giving to the child as well. So that is my take on this, but any other comments are welcome.
PET scan is definitely has value now. A lot of papers are there for neurogenic or neuroblastomas, let's say, which has got serotonin receptors. So beyond that, of course, you have papers on PET scan being done for Wilms tumors, etc. But more or less, I think PET scan should be a modality which should be left when we are reaching nowhere after doing conventional imaging. And but yes, even abroad, I've seen PET is being misused, I may say, at times.
Sir, I want to say, although I have little knowledge about that.
अरे तू बड़ा HOD है, तू हर बार ऐसे मत बोला कर. तू बड़ा आदमी है यार, ऐसे मत बोला कर. मैं देखा हर बार ऐसे कमेंट करता है. नहीं, you're a big man now. Please don't accept that.
Okay,
you're an HOD of a big institute.
This PET scan, I think this is the modality of choice during recurrence. And not only after recurrence, actually during metastatic workup, pre-operatively, we should go for PET scan. Ma'am is saying so much.
Are you talking about germ cell tumors, or are you talking about solid tumors in
any tumor, sir?
No, I totally disagree with you. We'll have to argue on one conference then. Pro and con.
Why,
you
sir?
May say pro, or you can get even Ankur also along, and I'll speak against.
No, sir. I can't contradict you, but it is my thinking.
You should start contradicting me. No, you reach that stage.
Okay, sir. But then CT, definitely, sir. It's if you do whole body MRI, it is a operator dependent, and nobody. You need a specialized person to read that actually. And
I know I can't read MRIs myself.
Yes, sir.
Even MRU, unless they make a big picture of it, MRCP. Many a times I can't read MRIs myself because we were not trained in reading MRIs when we were doing our MCH.
Yes. And PET is not operator
If
dependent,
we
sir.
don't do
So we
it,
can pick the
if we don't do it,
metastasis.
how are we going to get better? If we don't do it, how our situation is going to improve? We just keep saying that we can't read it and we don't know what to do.
No, ma'am. It is not the matter of reading, ma'am. It is actually the output. We can follow child of post-surgery also by PET scan, and that is more reliable, I think. I don't know what is the sensitivity in comparative with that MRI, but PET is definitely better than MRI.
No, not at all, because PET is a functional study and MRI is an anatomical study. We are comparing an apple to an orange. PET has its own value,
Yes,
and
ma'am.
MRI has its own value. MRI or CT, I'm talking of both the. Anyway, let us
Dr.
have this
Pablo,
discussion.
Dr. Pablo has put his comment here. I think that MRI is more useful to search for a small local recurrence.
Yes.
So,
well, MRI.
If you are looking for example, small lung nodules, also the PET scan can miss them. If you have if you are thinking perhaps you have a patient with a yolk cell tumor and you have to rule out pulmonary metastasis, sometimes PET scan is not enough for that because it can miss small nodules there, and it's high resolution CT scan is better for that. But for the pelvis, if we are talking about sacrococcygeal teratomas, if you are looking for a small residual or recurrence, I think the MRI is better. And I agree with you that we are not trained to read them in the right way, but we usually go to the radiologist and ask for them to read them with us, because I think it's a better study for that.
Okay, that settles it then. Any other questions, Dr. Manoj?
Yeah, there are more. Do we have time? There are comments and there are questions. Dr. Bagri is asking, did you review the slides, pathology slides?
Yes, sir. It was reviewed by Dr. Neha herself. But all are mature cells there. There was no immature cell or any bit of malignant tissue.
Dr. Chinmaya Mohapatra is asking that in the first case, as the AFP was raised, should we give neoadjuvant chemotherapy before going for upfront surgery?
I think it is already talked.
Yeah, we discussed this.
We already
discussed.
Dr. Akshay Kalavant is asking about management of SCT, which is an immature component in an excised specimen in neonate. I think that also is being covered.
I don't think so. Chemo is required in this case, because if we excise completely, I think ma'am will say, oncologist will say better. But COG protocol says if there is a mature cell and you have excised that, no need of chemotherapy if alpha fetoprotein is normal.
Yes, that's kind of known thing now.
So one query from my side: what is the recurrence rate in mature and immature teratoma? I mean, as per literature, is it more in mature? Really?
No. These are rare occurrences. I don't think you should be expecting recurrences in these categories if you've done a good surgery. And one comment I wish to make to what Dr. Sushmita was saying. Problem is that majority of the government institutions with huge workload, they would not like to do MRIs because it usually will need some short GA. So anytime we think that MRI has to be done, you have to ask the patient to go out and get it done from private, where they'll pay about 10,000-12,000 rupees, at times 3,000 maybe, but no good quality. So MRI, although most of the protocols for WIMS, let's say, they are saying move on from CT to MRI, but I think it's too early for us. Sure, as the things improve, in corporate, sure, you can go ahead and do it. But for government public hospitals where absolutely poor patients come, it's a little difficult for us as of now.
Yes, I think many centers face this problem. Dr. Sonali, any comment from you?
Yes, ma'am. So, someone is asking regarding recurrence rate of mature teratoma. So, recurrence rate is hardly 1 to 3% in different literatures. And of course, it is more in immature teratoma, but depending upon the grade, like grade 3 will have more chance of recurrence than grade 1 or 2. And regarding PET-CT, like Professor Sarin was talking, it is applicable to us also. Getting MRI is actually cumbersome, and this PET-CT is coming up. So most of the centers, they are doing PET-CT. It has good sensitivity and specificity also for picking up the metastatic cases. So many centers I know that they are doing. So, but it is not like recommendation. The conventional radiological investigations we are doing, but PET-CT is coming up.
Yes. Manoj boss?
So,
no, there are no
I
more
think we
questions.
should wind up. Anything else remaining?
No, there are no more questions.
Great. So, any comments from our faculty, all 5 faculty, any last comments that you want to make before we close the session?
Yes, ma'am, I want to make a comment. Definitely, this session has a great learning for me as well. This case was not mine, but I definitely promise if in this scenario, I'll take more and more sections and completely embed this specimen if possible.
Fantastic.
It was done.
Fantastic. So, yes, great. We all learned a lot today. And it was good interaction and discussion with all our faculty as well as our participants. And anybody else wants to say something? We thank all the faculty.
Anyone
Yes.
from audience, they can say. No one, ma'am.
So, okay,
Then
fine. Thank you. Rupsa, do you have the certificates ready?
Can I say one last sentence, please, if you don't mind?
Yes, sir.
I've seen very large malignant GCTs, sacrococcygeal most of the times, where chemotherapy worked so well that I couldn't find any tumor to resect later. So the only thing, if somebody had dragged me to the court, was that, oh, sure, I had the AP levels raised and this is the imaging. So I remember in one of the conferences, I put up a poster that if you are treating these patients with neoadjuvant without, so kindly take a needle biopsy, so as you have record of a histopathology with you. I don't know how well recommended is this, or how, I haven't read that. I will go through the literature and say whether this particular recommendation of mine still holds true or not.
Right. So, first of all, I should thank Dr. Basant for organizing this case presentations, and Dr. Yojana. No, I forgot her name.
Pujna.
For presenting the cases. And formal thank you to all our faculty, Dr. Pablo, Dr. Sonali, Dr. Neha, Dr. Rajanikant. Yeah,
Dr. Punita Lal.
And Dr. Punita Lal, I don't know, I can't see her only. We will be sending you certificates as faculty, and we will be sending certificates of participation to all our participants. So thank you very much. And our next session will be on neuroblastoma. We will have the medical and the surgical aspects of neuroblastoma in the month of September. So we'll reach out to you all with the dates and with the faculty as well. Thank you so much.
Okay. Thank you, everyone. Thank you for joining. Thank you, ma'am. Thank you, Manoj Joshi boss.
Thank you very much. Thank you.
Okay. Good night. Good night, everyone.
Thank you so much, everyone, for extending us the opportunity to host the session. So with all your permission, I would like to sign off here. Good night.
Okay. Good night. Good night.
Thank you. Bye.